first functional test we do is just a simple squat test. Really simple. What we're going to have her do is do 10 squats. She's going to go as low as she can comfortably. What we're looking for is symmetry between the limbs. If she's favoring one leg, keeping good alignment. We're listening for crepitus in and around the patellofemoral joint, looking for any signs of abnormal joint stress, obviously monitoring pain, any clicking or any abnormal signs of joint stress. So Katie's going to do 10 squats. Normally I'd be in front watching her from the front. Sometimes I'll put my hands on their knees to feel for any patellofemoral issues like chondromalacia. It's kind of a subjective test too. I need to ask the patient how that feels. If they're having a lot of pain with this, they're not going to be ready to enter the impact protocol. Simple but effective. If someone can't do this comfortably, then they're not ready to start the impact protocol. And that is the squat test. The next test we're going to do is the 1 minute eccentric step down test. What this is a good measure of is readiness to accept weight on the limb, as well as measuring what's called a force endurance ratio. It's a simple test. We do this pretty early on in rehab, frequently monitoring patient strength and progression with the protocol. What she's going to do, we're going to get a timer. We're going to time her for 1 minute. She's going to do as many dips as we can here, and I'll have her demonstrate here. We're not going to do the full minute for time's sake, but go ahead and start, Katie. We're going to count reps. She's going to go as fast and quick as she can, all the way straight with each rep. You're going to watch their form. People have a tendency to really hip hike on that, and if they're doing that, they're not doing this correctly. So we're counting reps for the entire duration of the minute. Okay, good. So say the minute's up. We're going to switch to the other leg. We start the timer, 1 minute. Here we go. Counting reps once again. After that minute is up, we divide the surgical leg by the non-surgical leg, and that gives us what's called the force endurance ratio, and that is what we use as one of our criteria to progress further into the protocol. We're looking for a certain amount of percentage, usually anywhere from 60 to 80% at the surgical leg compared to the non-surgical, and that is the timed 1 minute eccentric step down test. One of the functional tests we do in the program is a broad jump test. We do this towards the end stages of this program. It measures power, measures force production out of the hips and the quads. It's a good gauge for if our athletes are favoring one leg or not favoring one leg. So the way we do this is we usually have our patients do a graded warm-up. We make our patients interlock their fingers between their back, behind their back. This eliminates them using momentum. We want to measure power out of the legs. I'm going to have her do a graded warm-up. I usually tell the patient to do 2 jumps at 50% effort. So Katie, go ahead. So I'm watching her mechanics as she does this. She's going to return. We're going to do another jump at 50%. Good. One more. And we're going to ramp this up to a 75% effort now. Good. One more at 75. Okay, and now we're going to do 3 jumps at 100% effort, and I'm going to measure these jumps, and we're going to average these jumps. It's a good way for us to measure progress. So when you're ready, 100% effort. Good. Get a measurement. Go ahead and head on back. Again. So the hands are behind the back the whole time. Okay. Head on back. And one more. Okay, head on back here. So I'm going to take all those jumps and average them, and that's going to be our average for the functional broad jump test that we monitor throughout the later stages of the protocol. The next functional test we're going to do is the single leg hop test. This is kind of the gold standard as far as us measuring progression throughout the protocol. This is one of the biggest tests we look at if an athlete's ready to return to their given sport. It's kind of like the broad jump test. What we're going to have them do is we're going to do a graded warm-up. We keep their hands behind their back. I usually have them test their non-surgical side first. So what we're going to do is the graded warm-up. She's going to start with her right leg, 50% effort. Good, head on back. It's a good way we can measure patients' confidence in their leg too. Good, okay, head on back. We're going to do this at 75% effort. Okay, one more at 75. Okay, and now we're going to measure 3 jumps at 100% on her right leg, and we're going to repeat the process on the left leg. Okay, good. Okay, good. And one more. Okay, good. All right, she's going to warm up her surgical side now, same manner. 50%, okay, good. Okay, good, 2 at 75. Okay, and now we're ready, 3 at 100%. And I always tell my patients, don't go nuts. We're not trying to set records. We want you jumping comfortably. So I'm gonna get a measurement here. Okay, 2 more here at 100%. Good, and 1 more here. Good. So the way we calculate the hop index is I add all 3 jumps on the right leg, and then I add all jumps on the left leg, and we divide that total by each other, and it gives us a percentage. Our discharge criteria is an 85% hop index, meaning that the surgical limb has 85% the capability on the hop test as a non-surgical side. And that's the single leg hop test. One of the last functional tests we do is a vertical jump assessment. In order for us to get this set up correctly, I'm going to set this to our standing reach height. So step in, we're going to get the veins even with the tip of our fingers. And the top vein is 24 inches, so if you've got someone who can jump over 24 inches, you're going to have to adjust it accordingly. So what I'll have her do, we're going to do a few warm-up jumps, so 3 warm-up jumps, so get nice and low. And you're going to jump up and hit the tallest vein possible, okay? So 2 more there. Okay, so what I usually do is we get the veins that we know she's going to jump higher than out of the way, and then we're going to measure 3 jumps like we did in the broad jump test and the hop test, and average those jumps for a mean vertical jump assessment here. So now when she's ready, we're going to do 3 jumps and record those jumps at max effort here. That was 17.5 inches. That was 19 inches. Good. And that was 19.5. So we go by the tallest vein that she hit. So that is how we measure our vertical jump assessment. We do this in the later stages of the impact protocol.